All right, thank you. I'm pleased for this opportunity to present the management of Hodgkin lymphoma in the U.S. I'm here from Washington University School of Medicine in St. Louis. So I want to address the incorporation of brentuximab vedotin and the PD-1 inhibitors into frontline therapy, discuss some promising new salvage regimens incorporating those agents, and then finally talk about the management of Hodgkin lymphoma patients who have failed prior therapy with these effective new agents. So starting in the frontline therapy, we've had a recent update of the Echelon-1 study. And as a reminder, that randomized trial assigned over 1,300 patients with advanced stage Hodgkin lymphoma to either brentuximab vedotin with AVD or to ABVD, which has long been our standard frontline therapy in the United States. And in the initial reports of this randomized trial, there was an improvement in their modified progression-free survival endpoint in the BV-AVD arm. But in subset analysis, it looked like most of the benefit was in younger patients or in patients with a high prognostic score. And there was more toxicity with BV-AVD. So the regimen wasn't universally adopted. But we do now have a longer follow-up with a 6-year progression-free survival showing a continued benefit in the BV-AVD arm. And as well now a statistically significant improvement in overall survival. So this longer follow-up and now an overall survival benefit is, I think, motivating an increased use of BV-AVD in the frontline therapy of advanced stage patients. Brentuximab vedotin may also be beneficial when added to AVD in early stage patients. We don't have randomized data to that point yet, but in this single arm multi-institutional study, 117 patients were treated with 4 cycles of BV-AVD and then assigned to different radiation approaches, including one cohort that did not get any radiation. So most of the patients were PET negative after 4 cycles of BV-AVD. Those who were still PET positive went on to get biopsies, and it was rare to have biopsy-proven residual disease. And you can see in the progression-free survival curve, really excellent 2-year progression-free survival, including a 2-year PFS approaching 97% in the arm that didn't get radiation. So adding a highly effective agent like BV to the frontline therapy may reduce the need for radiation in these higher risk stage 1 and 2 patients. Returning to the advanced stage patients, nivolumab can also be added to AVD with good results seen in a single arm study. So this study enrolled 51 patients and showed that the combination of this PD-1 inhibitor with frontline chemotherapy was safe with no unexpected toxicity and high response rates. And still at early follow-up in this publication, progression-free survival exceeded 90%. So a American cooperative group study has just completed enrollment assigning patients with advanced stage Hodgkin lymphoma to BV-AVD versus Nivo-AVD. And we certainly await those results to help us figure out how to further refine our frontline therapies. So moving on to relapsed Hodgkin lymphoma, most Hodgkin lymphoma patients are eligible for autologous stem cell transplant if they fail frontline therapy. And our goal is to treat them with salvage therapy that will achieve a PET negative complete remission prior to the auto transplant. That's defined by a PET with a Deauville score of 3 or less. And that's based on retrospective data like the graph on the left, which is data from my own institution, and the prospective study on the right, which treated patients with ICE chemotherapy, followed by GVD chemotherapy if they didn't achieve a negative PET with ICE. And whether it took 1 course of salvage therapy or 2, as long as a patient is PET negative prior to auto transplant, they have very good progression-free survival. So if our goal is to get a patient into a PET negative CR before their auto transplant, what salvage regimen should we choose? We have a lot of options. That top line is the sequence of ICE followed by GVD from Moskowitz's study on the previous slide. There's also been a lot of reports of incorporating brentuximab vedotin with chemotherapy, and some of those studies are listed here. And then also on the last three lines, there are highly effective salvage regimens that use the PD-1 inhibitors, nivolumab or pembrolizumab. So I want to zero in on two of these regimens that I've been using regularly in my own practice. The combination of brentuximab and nivolumab has been studied by the U.S. cooperative groups. And you can see what durable remissions are achieved with that combination. This study enrolled 91 patients who were very high risk, 42% primary refractory, 30% relapse within 1 year of frontline therapy. 74% of the patients went on to an autologous transplant after 4 cycles of BV and nivolumab. And their 2-year and now, in a more recent update, 3-year progression-free survival is 91%. For the whole study population, the 3-year progression-free survival is 77%. So this is a well-tolerated outpatient regimen. We do see infusion-related reactions in a number of the patients, so pre-medication for the brentuximab is recommended. And a minority of patients have immune-related events, as we might expect with a PD-1 inhibitor. A more recent and smaller single institution report of pembrolizumab and GVD has received a lot of attention over the past year. This study actually enrolled at 2 centers, Memorial Sloan Kettering and the University of Miami, 48 patients, again, a high-risk group with relapsed and refractory disease. They were treated with either 2 or 4 cycles of pembrolizumab and GVD, and then almost all of the patients went on to an auto transplant. And at about 13 months follow-up, 100% of the study population is alive and in complete remission. Now, this regimen is an outpatient, generally well-tolerated regimen, but there really are a significant number of immune-related adverse events, as listed on the slide here. Some of these events were grade 3, and 5 patients required treatment with steroids to manage them. But nonetheless, this really outstanding progression-free survival curve has motivated the uptake of this regimen. So just one slide on post-auto transplant brentuximab vedotin. This is, of course, the curves from the Athera trial, which was reported 4 years ago now. And it's just worth keeping in mind that brentuximab vedotin is associated with a marked improvement in progression-free survival in patients who were treated on this study. So they all had high-risk disease at relapse, either primary refractory, relapse within 12 months, or relapse with extranodal disease. And none of the patients in this study had been exposed to brentuximab vedotin prior to their auto transplant, which rarely represents our current patient population. But inappropriate patients, maybe who haven't seen BV before auto, or who responded well to BV before auto, post-transplant consolidation with brentuximab is still appropriate. And so then finally, what do we do with the patient who has had multiple relapses and is no longer responsive to the PD-1 inhibitors and brentuximab vedotin? So these are the curves from the pivotal trials for these agents, which were all conducted in later lines of therapy. Some patients who get complete remissions to these agents can have durable remissions, but they are not providing long-term remissions for most patients. And again, in the current treatment environment, many of our patients are exposed to these agents in first or second line therapy. So what can we do after BV and PD-1 inhibitors have failed? There are a number of targeted and immunomodulatory agents that have activity in Hodgkin's, and I'll show that on the next slide. It's worth considering recycling chemotherapy in this setting. It has been observed that chemorefractory patients have a higher than expected response rates to chemotherapy after they've been treated with the PD-1 blockade. Some kind of priming and sensitization seems to occur. So I think reusing chemotherapy is a reasonable option and can especially be a good bridge to get disease control in a patient who's eligible to move on with an allogeneic stem cell transplant. And then there are some investigational agents I want to touch on. So just to summarize a number of small single-arm studies to demonstrate that the mTOR inhibitors, lenalidomide, JAK inhibitors, and HDAC inhibitors have activity in Hodgkin lymphoma and are worth considering in a patient who has failed multiple lines of therapy. Occasional patients will respond well to a variety of these approaches and may have durable remissions. Allogeneic stem cell transplant is a consideration for many of our Hodgkin's patients who have failed an autologous transplant and multiple lines of therapy. This is data pooled from 33 transplant centers. These are all patients who underwent allo transplant after having failed or been treated with PD-1 blockade. And then on the left curve, that top black line is the overall survival. And the red line progression-free survival. So you can see these patients can do well. There's been a reasonable concern for the risk of graft versus host disease in patients who undergo allo transplant after PD-1 blockade. But in my experience, that's does not arise in most patients, and we do have effective treatments when it does. The other curve shows a composite of GVHD and relapse-free survival, which was best in the patients who had a haploidentical donor and post-transplant Cytoxan as GVHD prophylaxis. A couple of slides on novel therapies still in clinical trials. This update was presented at EHA this year. Camidanlumab teserine is an antibody drug conjugate that targets CD25 conjugated to a PBD dimer. This was a population of patients who were very heavily pretreated, a median 6 prior lines of therapy. They'd failed BV and PD-1 inhibitors. And despite their extensive prior therapy, the response rate was 70%, with a third of patients achieving a complete remission. And you can see on the graph, the duration of response was impressive for the CR and even PR patients. Unfortunately, there were events of significant toxicities, especially Guillain-Barré syndrome. So some caution with the use of this agent, given its toxicities. Let's see, I'm not progressing. There we go. And no talk about lymphoma is complete these days without mentioning CAR T cells. Furthest in development for Hodgkin lymphoma are CAR T cells targeting CD30. This study enrolled 41 patients, again, a very heavily pretreated population, including a quarter of them having received prior allogeneic stem cell transplant. In the 32 evaluable patients, the response rate was very good with 59% CRs. Unfortunately, the durability of those responses was somewhat disappointing given the progression-free survival curve B. The study team, though, did report that the outcomes were better when they used fludarabine in the lymphodepleting chemotherapy as opposed to bendamustine. And also, better outcomes were seen if patients had a low disease burden at the time of CAR T therapy. So I think as we move forward with CAR T cell therapy and Hodgkin lymphoma, there's further refinement to do with the lymphodepleting chemotherapy and patient selection. So in conclusion, AVD is the preferred regimen for advanced stage disease, as long as a patient can tolerate the increased toxicity. Certainly, ABVD remains an acceptable and frequently used choice as well. In the salvage and second-line therapy, regimens incorporating brentuximab vedotin and or PD-1 inhibitors have very high CR rates and may improve outcomes after autotransplant compared to standard salvage chemotherapy. Whatever regimen we use in the salvage setting, the goal is to achieve a negative PET scan. So if I'm treating a patient and they don't have a CR to the first salvage regimen that I've given them, I will switch to a second salvage regimen to try to deepen their response before proceeding with transplant. Some patients will remain eligible for BV consolidation after the auto. And treatment after brentuximab and PD-1 failures remains a challenge. We've got multiple other options, allogeneic transplant, and some promising therapies in clinical trials. So I'll stop there and welcome questions.